Welcome to episode 104, Are We What We Eat? Linking Nutrition to Behavioral Health, featuring David Wiss, registered dietitian nutritionist, interviewed by Elizabeth Irias. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical. Learn, grow, shine. Hello to our listeners. Today we are joined by David Wiss. David is a founder of Nutrition in Recovery, which is a group practice that specializes in addiction, eating disorders, mental health, gut health, body image, and general wellness in Los Angeles. And he has a master's degree and is a registered dietitian nutritionist with a specialization in mental and behavioral health. David, thank you for joining us today.
Thank you so much for having me. I'm looking forward to this discussion.
So please tell us a little bit more about your background and how you came to have this specialization in these two, what we often think of as separate worlds, nutrition and mental health.
Yeah, I've always had the vision to bridge the gap between physical and mental health. When I did I did an undergraduate in social science, so I have some background in the social science world, and then I switched over and did a master's of science in nutrition. And studying nutrition is very reductionistic. We learn about mechanisms and we learn about vitamins and minerals and calories, and there's a lot of math. And I always had this hope that one day we collectively, scientists, could bridge the gap between the medical world and the social science world. And in doing so, I became interested in the link between nutrition and mental health. My first interest was in the role of nutrition in substance use disorder recovery. As everyone knows, there's a huge addiction crisis. And early on, I was thinking about topics for my master's thesis. And I thought, what about the connection between not only nutrition, but also eating behavior for people at early recovery from addictions? And I learned pretty quickly that there's a large overlap between addictions and eating disorders. So the co-occurrence is somewhere as low as 3%, and some studies have shown as high as 50% overlap between addictions and eating disorders. And I also learned that there was no standards of practice for nutritionists who work in addiction settings. So there was a requirement for nutrition services in eating disorder treatment. There's requirements for nutrition in long-term care, but there was no established standards of practice for addiction treatment. So I took deep dives into the literature. I did a master's thesis called Nutrition and Substance Abuse, where I was able to see what has been studied, what are the links, and what is known, and where are research gaps. I quickly learned that there was a huge research gap in this area, and there was very few studies that were actually looking at nutritional deficiencies, eating behavior, and outcomes in these types of settings. So my master's thesis was at the VA, and we looked at eating behaviors in people that were in recovery. But to summarize it all, nutrition for mental health is a broad category. It really thinks about what we eat, obviously, nutrients. And the original studies that I saw linked nutritional deficiencies to certain psychological conditions. So for example, B vitamins or vitamin D or iron-related labs have been linked to depression and other mental health conditions. So that became the focus. I'll call it, in the early 2000s, 2010, the research was designed to look at what vitamin and mineral deficiencies are linked to what psychological mental health conditions. And then with the addiction research, they were looking at what vitamin and mineral deficiencies would be linked to specific drugs. So for example, does someone who uses heroin have a more likelihood of being deficient in this vitamin versus someone who uses alcohol? Is someone who uses cocaine and stimulants different than someone who uses benzodiazepines, for example? So the kind of early assumption was, if we can figure out what nutritional deficiencies are associated with what conditions, if deficiencies could be corrected, then the conditions could be improved. Now, that was the starting point. Now, I want to say that since that time, there's been a huge emergence of other science, which has shown that it goes way beyond individual nutrients. And that's kind of what I'm hoping we could talk about today, is not just nutritional reductionism, looking at single vitamins, but actually looking at the entire picture of the human. So whole body processes, microbiome, inflammation, the role of adversity, etc.
Thank you. This is something that's very interesting to me, and I know for a lot of our listeners, these words you're using, like microbiome, they're only things that, at least in our field, we've only just now started talking about, and certainly more and more research coming out about the importance of gut health and how it plays into mental health. So why don't we start there? Why don't you just start explaining what is a microbiome? How is that different from person to person? What does adversity have to do with it when we look at trauma and childhood development?
Awesome. Yeah, thank you. So the term microbiome describes the collective genome of all of the microorganisms that share our human space. Now, the reason why this has become so popular in recent years is because we have the technology to test for these things better. So there's something called whole shotgun genome sequencing, also known as 16S RNA, where basically samples can be put into machinery that essentially extracts the genetic material. So for example, one could take a swab from the back of an ear, from a feces sample, and put it into an analysis that would essentially map out the genomes. And that allows us to understand the microbiome. The microbiota is a similar term that just describes the microorganisms rather than the specific genomes. So they're used interchangeably often, but they're different things. So I think for the sake of today, we'll just use the term microbiome because it's the more commonly used term. Now, most people think microbiome and we think the gut, right? However, there's other parts of the bodies that obviously have microbiome. For example, dentists are studying the oral microbiome, etc. So we're also going to mainly focus on gastrointestinal microbiome. The truth is, it's very much in its infancy. I'm sure there's going to be a lot of funding and a lot of new findings in the upcoming years. We're certainly working on some exciting stuff. But I think at the most basic level, we're able to see associations between certain health conditions and microbial disruptions or perturbations. I'll just highlight some of the major findings that are important for mental health. I think the biggest one that really opened people's eyes to the importance of the microbiome was this idea that serotonin is mostly produced in the intestines by way of gut microbiome. So the highly cited literature says that around 90% of serotonin has an intestinal source, and about 50% of dopamine is produced in the gut. So previously, we've always known that amino acids, which are parts of protein, are precursors for neurotransmitters. But it wasn't really clear, how that conversion process took place. And so what's become more clear is that the bacteria, which is mostly what we're talking about, there's other microorganisms that we're not going to focus on today. The bacteria is responsible for breaking down the food that we eat and converting them into other compounds for use by the body. So most people, when you think about eating food, think about a warm environment in the stomach that's just maybe making some pressure, moving some things around, and absorbing things through the intestines. But it turns out that the other living organisms that are not us but live inside of us have the role of breaking down these foods, specifically these fibers, and converting them into other things such as neurotransmitters, short-chain fatty acids, and a host of other compounds that are sent through the blood to the brain and to the other organ system. Now, this changes everything we know about medicine and about health. And when I teach nutrition to people, and I'm able to go beyond calories and go beyond vitamins and minerals and explain to people that there are 2 to 5 pounds of invisible life inside of your gastrointestinal tract that is responsible to break down the foods that you eat and create, we have a new term, by the way. We talk about probiotics, meaning bacteria. There's a term, prebiotics, which is the food that the bacteria eat, which is most specifically types of fibers. And then the new term that's emerging in nutritional psychiatry is postbiotics, right? Which is all the different byproducts of the microbial degradation. So when I'm teaching people about the role of gut bacteria in converting food into things that are needed for the brain, people are able to receive it in a way that might create more motivation for changing eating behavior. So, for example, if it was just vitamin and mineral deficiencies, the way I kind of kicked it off today in our discussion, if it was just that, then taking a vitamin or a mineral supplement would fix the problem, wouldn't it? And it turns out that that was the original assumption that was around. And now, again, I'm not anti-supplements at all, and I'm not anti-vitamins and minerals, but that was the very incomplete picture that left people very confused. How come when I take a vitamin and mineral, it doesn't necessarily translate rapidly or even, slowly to noticeable changes in my mood and mental health? However, when we talk about fibers in foods and polyphenols, which are antioxidants, all being a part of the equation, we're talking about synergy created by food that doesn't just act on us, but acts on the ecosystem inside of us, which then informs various metabolic, immune, and mental health processes. So hopefully that's a good overview of the gut. The one other piece that's important there, linking the gut and the brain, there's several pathways, and I doubt we'll be able to cover them all. The other one, which is quite relevant, is the role of inflammation. So it turns out that there's a difference between acute inflammation, which is, if you were to cut yourself, there would be an obvious inflammatory process that's happening. The immune system is acting up, versus like a low-grade systemic or chronic inflammation might even be something that you might not even know is happening, right? It turns out that as gut microbiome is disturbed, and what I mean by disturbed, I should probably define that. The ideal gut microbiome has a wide range of bacterial species. As people have low quality diets or become distressed, which hopefully we can come back to, they lose out on beneficial bacteria. So over time, what happens is there's a loss of species, and that in turn can create inflammatory cascades, right? So the inflammation that starts at the gut by way of poor nutrition, by way of stress, by way of lots of other factors, can create low-grade systemic inflammation coupled with loss of bacterial species. And those inflammatory processes, we now know, create immune reactions, cytokines, etc. And those are traveling all over the body. And more specifically, where I'm interested is how inflammatory markers can cross the blood-brain barrier and essentially cause neuroinflammation, which is inflammation in the brain. So this is probably the most exciting link between nutrition and mental health, which is that the food we eat isn't just vitamins and minerals. It isn't just calories. It's profound information that informs the composition of our gut bacteria and can either reduce or promote inflammatory processes, which over time, not like I said, acute, but chronically over time, can affect our brain. And when that message is carried to people that are looking to make nutritional changes, I think a lot of people are able to wake up and say, that registers. That gives me the real why. Because everyone's always known, if you eat better, you feel better, right? Food and mood, these are all things that we've all said for, right, years. But when we actually can understand the mechanism and explain them to people, it makes a stronger case of why nutrition interventions should be guided in certain directions versus others.
Absolutely. And I can see already the obvious link with mental health conditions and addictive disorders, in that typically when people are stressed or depressed or in the throes of a hypomanic episode, they're not eating well because they don't feel good, or they feel very, very good and they don't feel like they need to eat. And alternatively, people that have addictive disorders are often neglecting primary needs like nutrition, not to mention things like sleep and sometimes hygiene due to the severity of possible addictive disorder. So even right there, you're laying the groundwork to create a series of problems from a nutritional standpoint that would just build upon themselves to make things worse.
That's right. So when we look at someone, for example, with heavy alcohol use and prescription pill abuse, there's obviously some harm caused from the exposure to the substances, as well as harm caused by poor nutritional intake, right? So that combination creates challenges. One of the big breakthroughs in alcohol research in the last 5 years has been that the way we understand the pathogenesis of alcoholic liver disease has changed. The original assumption prior to all this knowledge about gut health was that alcohol, which is ethanol, converts to acetaldehyde, and these are toxic substances, and those in combination accumulate and cause damage to the liver, which would lead to, over long periods of time, liver disease. It turns out that assumption or theory is a totally incomplete picture. The real problems associated with alcohol and other substances is the damage that it does to the gut. So alcohol causes dysbiosis. Dysbiosis is the term we use when there's a loss of beneficial bacteria and a growth of parasitic or pathogenic bacteria. And the dysbiosis leads to inflammation. The inflammation leads to intestinal permeability. Intestinal permeability is the kind of fancy medical term for what people know as leaky gut. And leaky gut means that there's some small space in the tight junctions of the intestinal barrier where small particles can leak through. And when I say particles, we're not talking about food particles. We're talking about particles from bacterial cell wall, or LPS, a lipopolysaccharide. These things can enter in the bloodstream, and over time, that gets passed through to the liver. And these little particles from the intestinal permeability over time are taxing the liver, where the immune system is acting up. And the alcoholic liver disease is not caused by the ethanol directly. It's caused by the indirect effects of ethanol on the gut. And the gut leakiness is where the liver damage occurs over time. So when we deal with people that have substance-related issues, and I use the alcohol example because it has the most pronounced effect on the gut, what we're looking to do is truly aim to heal intestinal function, right? Because, for example, if someone has dysbiosis and intestinal permeability, maybe taking vitamin supplements might not be absorbed all that well, right? Another hot topic is the opioid crises, right? And if anyone's familiar with the way opioids work, there's often constipation. Sometimes people go 10 days, 2 weeks even, between bowel movements. So, researchers are starting to look at, what might happen in the gastrointestinal environment when the digestive process is slowed down. In other words, what opportunities do pathogenic bacteria have to grow and to proliferate? So it really caught my attention. A few years back, there was an animal study that showed in mice given morphine, they had one particular strain of bacteria that was increased by 100-fold compared to controls. Now, as a nutritionist that works with people with opioid disorder, these things start to get my attention because, it's like, what if the drug itself is, leading to an increase in the abundance of a certain strain? It's hard to make those causal inferences at this point. But, for example, there's a known association between opioid withdrawal and recovery and sugar craving, right? So it starts to lend these really interesting questions. What if changes in gut bacteria from a specific substance was driving other cravings for other things? Obviously, we know that the major overlap there is the dopamine system, right? Someone is no longer having their major source of neurochemical reward. They're going to find other things to replace it. We call it cross addiction. But why is it that there's specific known associations between opioids and sweets that's stronger than some of the other substances, right? And those are the kind of research questions that haven't been answered that, hopefully I'll be able to make some contributions to.
Thank you for covering more of that and breaking down what these different things mean, what what dysbiosis means. And what you're saying about morphine, I think, is so interesting. And I'm sure we could have a whole nother talk then about the impact of things like antibiotics on gut microbiome and how that factors into all of this equation. And then looking at the link, if we weren't even thinking of it as mutually causal, but looking at how much a condition like irritable bowel syndrome or celiac disease or anything else would almost invariably affect mood, because it would affect how you feel as you're walking around the world. So it can't just only affect the body. It invariably is going to affect the brain and mood. So tell us more about the substance use piece. I think what you're saying about morphine and opiates is fascinating. Tell us more how you see, so when you're working with somebody in your office that has a substance use disorder, where you start nutritionally, so that our listeners as mental health professionals, knowing that most of us are not nutritionists and so we need to refer to someone like you, but what do we need to be paying attention to? Because I know I've worked with so many people that are in recovery, and then when you ask about their diet, it's like, oh,
Mm-hmm.
And then they're like, well, if you count pizza and Coca-Cola, and then it kind of goes down from there. So tell us about your experience with that.
Yeah, thank you. The most predictable patterns for people that have, severe or even moderate substance use disorders is across into caffeine, nicotine, and sugar sweetened foods. There's also a predictable pattern of not eating breakfast, which I wouldn't say is substance use disorder specific, but is a kind of known kind of epidemic, I'll call it, in our current climate. Part of the reason, as I stated, is, caffeine, nicotine, sugar are obvious cross addictions that create a predictable neurochemical response that is basically required by the brain for some people, especially with there's underlying unresolved trauma, stress, and adversity, right? The brain's going to need to find something. But I've also noticed that people going long periods of time actually also increases the neurochemical response to food. So a intervention that I would commonly like to do with someone is to get them eating more regularly and consistency throughout the day. Let's call it 5 small meals, right? I use the mantra, consistency with food leads to consistency with life, right? If you were to kind of let someone make the choice based on what quote unquote feels good, the predictable pattern, and obviously I'm speaking broadly right now about, the overall people in recovery, which is extremely heterogeneous, would eat most of their food in the second half of the day. And that would be predictably because by the time you get really, really hungry, food tastes way, way better. So there's a larger dopamine response. In other words, hunger is the best sauce, right? So people will typically wait until they're very hungry to get a larger reward from the food. And then late night eating also might help with sleep. There's a lot of medications that are out there that also increase appetite, so specifically in the evening. I do want to make a quick side note, and I'll come back to your question. Before I forget, there's a lot of really great research coming out of Ireland where they're actually looking at how medications affect gut bacteria. And that's a really hot topic because people have known for a long time certain antidepressants, SSRIs, are associated with weight gain. And the question has always been unanswered. Why, right? Like, people assumed based on the calorie hypothesis that obviously someone might be eating more, or there was the kind of metabolic hypothesis, which suggests that it actually changes, metabolic hormones. But now there's this kind of emerging question: what if it was changes in gut bacteria that actually impacted weight status? And that's a really hot topic. The data shows decreased bacterial diversity as well as increased permeability at certain parts. One study showed the ileum, which is part of the digestive tract. So that's a hot topic. If I'm dealing with someone in recovery, I'm going to want to obviously know about their medications and emerging information about how that can affect gut to make the stronger case to focus on gut-based nutrition interventions. I'm certainly going to want to get someone on a kind of patterned way of eating, not overly patterned. Like I said, there's a lot of overlap between addictions and eating disorders. So the biggest challenge is being sensitive to someone's level of cognitive rigidity, because the last thing you want to do when you're teaching someone how to eat healthfully is to go too far and turn them into a new obsession, right? So it's a real challenging, it's almost like an art of balancing, getting someone to, I mean, in the simplest form, to stop eating junk food, right? And then in a more practical form, to not turn that into orthorexia nervosa, which is an extreme obsession with the quality of food. So everyone's different. So people need different messaging, which is why running a group in a addiction treatment center is challenging, because some people are more on the restrictive, rigid, trying to go onto a keto diet or do fasting or doing dietary extremes, I call them. And other people, and so they're more sensitive to nutrition messaging, right? They might take something and run too far with it. Whereas the next person might need a more practical message of like, no, higher quality diets, including more fiber, more omega-3, which often comes in a fish oil supplement. If not from fish, you can get it from chia seeds, flax seeds, and walnuts. Getting more fruits and vegetables, like eating healthfully is going to improve your mental health. That is a very clear and important message. However, when we talk about mental health, we also have to think about the preoccupation that some people have. One of my intake questions when I meet with people is, what percentage of the day do you spend thinking about food? And what percentage of the day do you spend thinking about body, right? So even if someone doesn't have any nutritional deficiencies or mental health diagnoses, if someone spends 70% of the day thinking about their body and they spend 50% of the day thinking about food, that's a mental health issue, right? And so those are really important considerations, which make the work that I do specifically challenging, because, with addiction recovery, we want to teach people how to eat better. And sometimes with disordered eating, the challenge is not how to eat better, but how to think differently about foods, right? So those goals are not at odds, but they do require expertise in both areas in order to be successful, and most importantly, to do no harm.
I think I'm writing down the question that you just asked on intake of what percentage of time do you think about food or do you think about your body? I can think even for myself about past clients, just this preoccupation. And also I know for some clients, what an unbelievable source of guilt, that it's like, well, I'm not eating. And so then I eat, but I know it's not healthy. And then it becomes this self-fulfilling prophecy that they keep feeling sicker, but the cycle just persists. So we could go lots of different directions from here, but I would love to hear more about the research through your eyes relating to in utero exposure and trauma. I mean, I having 2 children myself, I remember seeing some of the studies just out of my own curiosity, looking at maternal mental health and impact on children, and seeing studies about, the amount of stress that mom was under and subsequent low birth weight and things like that. So I could see how we are then setting a baseline before birth relating to basically what's going to be out in the world. Will there be not enough food or nutrition to serve me? How stressful is the environment? And so then I would assume, given epigenetics, our body is adjusting to that before we're even out in the world. So tell us how you see all of these pieces kind of fitting together, and what mental health professionals should understand about that component. That I'm going to guess you're going to start with, it's not as simple as, hey, don't eat as many burgers, or eat more fruit or vegetables, because it's much more complex complex than that.
It's always complex. And to kind of finish an earlier thought I had about bridging the gap between social and biological sciences and psychological sciences, right? This kind of work that, we do, in line with the question you asked, I would call fitting under the biopsychosocial model of health, right? Which is really an effort. It kind of was introduced by Dr. Engel in 1977, and it was an effort to look at all the microscopic factors, atomic factors, now bacterial factors, all the way to the cellular, organ, individual, family, community, environmental, to the planetary level, and being able to look at how all these different factors interact to inform health, and really being able to look at individual differences between people. The other scholar that I want to reference is Dr. Nancy Krieger, who's now at Harvard. She's a social epidemiologist. She used the term embodiment many years ago to describe the literal incorporation of one's environmental circumstances into our everyday lives, right? So most people are familiar with The Body Keeps the Score, which is a very popular book of how trauma and early life exposure gets underneath the skin and becomes biologically embedded. The reality is doing that kind of research on humans is challenging, because you can't obviously do any kind of trials. You're not going to ever assign people to an early life exposure adversity group, right? So it is difficult to be able to ascertain, for example, you mentioned intergenerational links of trauma, right? But it's happening. I will say that I was involved in a major review article in the Appetite Journal, which looked at preclinical data, which is animal data, linking what a mother eats during pregnancy, and obviously these were rats and mice, to the neurodevelopment of the offspring. So I think we reviewed close to 200 papers, and it was very clear that extreme diets, so either really high in sugar or high in fat, imbalanced, right? Western diets, we call them, chips to Oreos, ice cream, that kind of thing, actually program the offspring for more likelihood for addiction-like behaviors. And that would include drugs, amphetamine, as well as food. So the major premise of the article was focused on food addiction and addiction transfer through maternal influence. So it has been shown pretty clearly in animal models that extreme Western diets, particularly in the third trimester, can make their offspring more susceptible to addiction processes. In other words, the overactivation of the mesolimbic dopamine system is passed along to the offspring. So if you put it into social context and think about, the quote unquote junk food era that people refer to started in 1980, where people ate more commercialized food, more packaged food, did less cooking at home, and ate more, I like to call it corporate food. It's a good way. It's a kind of, people get that. It's food that's designed for maximum profitability, right? Which means that there's typically some added sugar, salts, fats. There's typically some things that have been removed, fibers often removed, and there's other ingredients that make it all come together that are actually potentially harmful for gut bacteria. Is that our exposure to this kind of westernized way of eating, particularly for mothers during pregnancy, can be setting up offspring for higher likelihood of addictive processes. Now, that hasn't been proven in humans, so I do want to state that, but it's a theory that's starting to make sense, especially to me. Then you throw in a little bit of trauma, and then you throw in the smartphone and the internet, right? And we've got the addiction crises, right? Obviously, the opioid crises is linked to the environmental accessibility of the drugs, but the major questions that we have to look at in the opioid crises, for example, is Where does all the pain come from in the first place? Why are people more susceptible to getting addicted than, maybe they used to? And as a, nutrition researcher, I'm interested in how has the highly palatable food that we've been eating been programming our reward systems to make us potentially more susceptible to other addictive processes? And that's a really interesting question. When we look at addiction as an outcome, one of the most well-established risk factors is the psychosocial vulnerability from trauma. If you were to think about like a causal pie, like what would set someone up for drug addiction? If there was a genetic component mixed with psychosocial components, stress, trauma, adversity, and then there's like exposure, chronic exposure to the substance, you're almost, you're very likely to end up with the substance use disorder phenotype. Now, some people don't use drugs because they are illegal and stigmatized. I'm interested in the link between those vulnerability factors and food addiction and eating behavior, right? Which, also can lead to obesity or to eating disorders, which, really takes a look at a life course approach to early adversity, how that becomes biologically embedded, and how that can translate to behavioral mental health outcomes, whether it be drug addiction, food addiction, or eating disorders. Those three are highly intertwined and overlap. They can exist independently, but they can all coexist at the same time and at different parts throughout the life course. And they can affect people's weight in ways that might affect quality of life and other health parameters. And it's starting to get really interesting because nutrition is no longer just a vitamin or a calorie or a food label. Nutrition is, a potential medium for behavioral health. So overeating, undereating. One of the real interesting areas of inquiry that I have, and I ask sometimes this in my intake with people, is I want to know their highest weight and their lowest weight. Sometimes the amount of fluctuation that someone's had throughout their life can inform certain things about their not only metabolic health, but also mental and behavioral health. If someone has been in a pretty tight range, right? They've been like, within 15 pounds on either side for most of their adult life, it tells a different story than someone who's been up and down 75 pounds on both ends a few times, right? Those are totally different stories. So as a behavioral health nutritionist, I'm interested in looking at things like that and things like, circadian rhythms. What time do you wake up and go to bed every night? If someone has erratic sleep patterns, that tells a very different story than someone who goes to bed and wakes up at the same time every day. If someone has a bowel movement at the same time every day, it tells a very different story than someone who sometimes is constipated, has diarrhea, has erratic, bowel patterns as well. So I like to think about nutrition as an important medium by which you can set up homeostasis and consistency. Because in any form of recovery, whether it be addiction, eating disorder, trauma, typically one of the goals is to create that position of neutrality, right? Where you're less susceptible to extremes on either end. But to come back to your original question, the biological embedding of adversity, super hot topic. There's a lot of different pathways by which early life adversity can affect mental health over the life course. We've talked about the reward system already a little bit. We've talked about inflammation. That's one known pathway. One common way that inflammation is operationalized in research is a term called allostatic load. Basically, you take an index of several different inflammatory markers and you can measure it to make stronger associations in the data. Another pathway is the HPA axis, which is the hypothalamic pituitary adrenal axis, which is responsible for the human stress response. The output is glucocorticoids, specifically cortisol, which is the known stress hormone. So people that are exposed to adversity early on in life can have epigenetic changes where their human stress response is different compared to, let's just say, controls. That's a really hot topic in epigenetics, is the glucocorticoid receptor, how that can be altered through adversity. It's also important to note that there are critical and sensitive periods where the exposure to the adversity matters. In other words, how does sexual or physical abuse between ages 3 and 5 differ from between 10 and 12, right? Those are things that research are starting to look at. How does different types of adversity affect people differently? In other words, does household dysfunction, parents getting into fights in a divorce, differ from neighborhood bullying or other forms of adversity, for example, abuse, right? Physical, etc. That's a really hot topic. It's important when you think about adversity affecting behavioral health over the lifespan to think about, obviously, vulnerability factors. Why is it that two people can be exposed to the same thing and have completely different outcomes, right? Someone's at heightened risk for psychiatric disorder and the other person has displayed resilience, right? Why is it that someone can bounce back from an adversity and have a stronger phenotype compared to the person who might have a trauma exposure that, and I know this is going to sound dramatic, is not easily redeemable by subsequent experience, right? And these are the types of cases that we often see. So genetics plays a role in both, in my opinion, and based on some of the research I've seen in the vulnerability factors. And then social science is probably more involved in the resilience factors, right? Someone's access to resources, their ability to go to treatment, etc. Those things seem to matter. Other pathways between the biological embedding of adversity and mental behavioral health include the microbiome. So that's a kind of new area. There aren't a lot of studies, but there's definitely about a dozen. I know that there's some research that shows that stress has a similar effect on the microbiome as, for example, alcohol does, which, right, it's hard for people to wrap their mind around this. How does stress change the bacteria that live inside of you, right? And I think there's a lot more research there coming, and I'm following along closely. There's also research on telomeres, which is a biological indicator of aging. I'm not quite an expert on telomeres yet, but I know that it's an area of investigation for how early life exposures can affect health. The other hot area is the vagus nerve, which is the largest nerve in the autonomic nervous system that connects the back of the brainstem to the various organs and has bidirectional communication. So it's a primary communication network between the gut and the brain, which is impacted by trauma. Fascinating research happening there.
Okay, I'm bringing all these pieces together as you're talking about it, and what you're saying about telomeres and DNA, and I mean, what you just said about stress and the microbiome and alcohol use is kind of mind-blowing. And to quickly comment, what you had suggested earlier in this idea that the mother's consumption of sugar, which we know has a biological impact on the mom in that moment, but how it could be affecting a baby. And where my brain went also was, well, what about breastfeeding too? Like what happens in a mother's diet, or if a mother has excessive stress while they're breastfeeding as well, how is that affecting the baby, knowing that there are all these things about breast milk that we don't understand at all, that are so intricate. I'm so glad we're having this conversation. My mind is just kind of sitting here being blown over and over and over again by all of the things that you're sharing. So, and I cut you off, please keep going where you were, but I just wanted to comment on some of these things that you were suggesting, and this idea that, again, we come back to this point that things are way more complicated than we've given them credit for.
Way more complicated. And, science is only able to capture what it's able to capture. And it's an iterative and, moving target often. Your point about breast milk and was well received. And in our animal data, we did look at that as being an important predictor of the outcomes as well. But what I also want to add to the pregnancy thing is that overconsumption is problematic, but underconsumption and restriction is equally problematic. If some might argue more, right? So it goes back to my original point. If you're going to tell people, too much sugar during pregnancy can make your offspring more susceptible to reward-seeking behavior, right? That might lead someone to, eat none and go really restricty and be orthorexic during their pregnancy and make sure they don't gain as much weight. And that could be problematic as well, right? So it's a perfect example of the balance between trying to teach food addiction and drug addiction science, but also put it in the social context of like, yeah, we live in this society where certain things aren't easily accessible for people. Dietary restraint can be problematic. There's a lot of stigma around weight and nutrition. And these are all things that kind of bridge the gap between the biological science and the important psychological parts of it as well. The last pathway that I think is worth mentioning, I think this is pretty hot stuff, at least in my world, is how trauma can alter some of the functional and connective parts of the brain, specifically PTSD leading to reduced hippocampal volumes. So there was a recent systematic review and meta-analysis that did show that trauma reduces hippocampal volume, which hippocampus, as we know, is involved in memory as well as other processes. This is a real example of how adversity is biologically embedded and really can be challenging to quote unquote reverse, right? Certain epigenetic things can be reversible. How reversible is altered reward pathways? We don't know. But one other area of inquiry there is that amygdala volumes have also been shown to increase. So that has less strong evidence than reduced hippocampal volumes. But, those of us that work with, behavioral health, know the importance of the amygdala, right? We're dealing with emotions. That's where things like anxiety and depression and even cravings are often generated through. So if someone is, let's just do a hypothetical case study, someone is, comes from a generational legacy of trauma. The mother learned that, you can eat whatever you want during pregnancy, expose themselves to a lot of highly palatable food. The offspring grows up in an adverse environment, is exposed to a lot of sweetened, salted, and processed foods. And then they get exposed to their own forms of adversity, have susceptibility to the biological embedding of adversity. And then by the time they are in their early teens, they're already full-blown addicted to their smartphone, to the internet. You're basically setting up a challenging road in terms of, life outcomes. So I'm of the belief system that in order to address the addiction crises and the obesity epidemic, to be able to address eating disorders, we need to look at, obviously, most people would agree with this, trauma-informed treatment, better screening, and not just screening, but actually getting people the help they need. In California, there's approved protocols for ACE screening. ACEs are adverse childhood experiences. There's a major study that came out of San Diego Kaiser that showed that adverse childhood experiences are significant predictors of injection drug use. Obesity was significant as well. So 22 years later, after hundreds of studies have been done, they finally approved screening for ACEs in primary care. The real question is, once someone shows up and has 5 ACEs, right? What do we do with them, right? That's an important question. And I also believe, as a nutritionist and as a public health academic, that's what my current PhD journey is in, public health. I think we need to look at the food environment as well. I think that giving food corporations the green light to do whatever they want is eventually going to come to light as being completely unacceptable. And I do think that we're going to need to, target the food companies the same way we had to target the tobacco companies, because their pockets are deep. They're able to fund research, which shows that all their foodstuffs are safe, and it's going to be a long battle ahead. But, they've been able to control the public discourse around nutrition. They always want to circle people back to the message of a calorie is a calorie. They want people to focus on nutrients like vitamins, right? They can say this is low calorie and it has vitamin, but it's like an artificially sweetened beverage with artificial colors in it, right? So from that old lens, that would come across as, oh, it's a positive health enhancing thing. But from the new lens, you would say, no, actually artificial sweeteners induce glucose intolerance, reduce bacterial diversity, and supplemental vitamins are not absorbed as well as they are in the context of fibers and antioxidants in food. So that might not be a good choice at all. From a calorie standpoint, someone might make the argument that it is. From a gut health and mental health standpoint, you could say that's actually not optimal at all. So I do think that in order to reduce some of the crises we're in, we are going to have to look at food. I really do. How we educate people during pregnancy, how we message nutrition in early life, and the types of services that people are able to access later on. It's a shame that, my services are not covered by insurance, and people can get reimbursed through their insurance company, but it's such a nightmare that, right, to have trauma and addiction and be binging every night and not have insurance cover nutrition services, right, is, it's disappointing. It points to the reality of our kind of system as well. But yeah, I see change happening, and I do think that in order to, manifest all that, the most important thing is to change the way we think about food, and obviously, if we're talking about policy, to do some really good research that shows that nutrition affects mental health over the life course in the short term as well as in the long term. And the good news is that there are movements happening, right? I'm not doing this alone. There's the International Society of Nutrition Psychiatry Research. They just had their 3rd annual conference in London. I was able to present there about substance use disorder. And there's a lot of global efforts to link nutrition to mental and behavioral health. But I will say that a lot of it's not here in the US. A lot of it's in the UK and Australia and these other places. So I would love to see more focus on that here in the US, particularly as we think about early life adversity and addictive disorders.
So one of the things that we struggle with as behavioral and mental health providers is we have this very clear lane. We're not dietitians. It's not a specialization. And I think there's only so much that we can do, in providing information and saying, oh, goodness, it would be much better and your body would get better nutrients and your microbiome would be improved potentially if you had more regular eating habits. I've had that conversation, the breakfast skippers and the people that eat one meal a day. And I've certainly had those conversations. At what point do we really need to simply tip our hats to the folks like you that know so much more about all of this than we do? Where do we draw that line? And what other resources for the people that don't have the funds to be able to see a dietitian? What do we connect them with for our patients and clients that are in the room so that they can start to learn about this stuff? Because so many things that you've presented today, I had no idea about. I'm sure our listeners didn't too. And if I don't know about them, if other people don't know about them, then we're not conveying them to clients and patients. And so there's this gap.
I actually been getting that question a lot lately. I've presented quite a few times to mental health professionals. And since I've been working on my doctorate and, being up to date on current research, doing some research of my own and disseminating these findings, that's the question. How do we bridge the gap between nutrition and mental health? How do psychologists, marriage and family therapists, social workers help people? How do we, stay in our lane, when to refer out? And that's the question. It really is. I mean, certain things that I think mental health professionals can do is, and this might even be a little controversial, is just help people think about like when to eat and just being in a rhythm with food, because the lane is like when you start telling people what to eat. That's a little bit on the edge. But when to eat can make sense, right? There's a large movement in the intuitive eating world, which I am a supporter of, that would say, just eat when you're hungry and stop when you're full. And I think that works great for some people, especially if they're part of diet culture, right? To get them off of this rigid diet train. But for other people who have inflammation and, metabolic issues and altered reward sensitivities, that's really challenging for them. So they often need a little bit of structure in the beginning before you can get to that intuitive eating place. So when to eat can be important. And then, like I said before, thought life around food and body, those things are important. Being able to assess someone's level of cognitive rigidity and dietary restraint as part of the kind of screening for eating disorder process, I think can be really, really helpful. And then, obviously when there's eating problems that cause, impairment and distress, right? Those are the times when hopefully someone like me could be helpful.
So someone like you, as in a registered dietitian, I know for me, it was only recently that I sat down and actually looked at what is a nutritionist versus what is a dietitian. And certainly, just to reiterate for our listeners, who you're wanting to refer to is someone who's a registered dietitian. So someone who has specific knowledge in this that has been monitored and evaluated and tested, that this individual is educated in this and has the appropriate education and background to be sharing this information. Is that right, David?
That is right. But I will say that most of the stuff I talked about today is way outside of that lane. So dietitians are not necessarily trained in stress, trauma, and adversity and mental health. That is something that I've taken interest in professionally as well as academically. So, it's always smart when I think most mental health professionals know before you refer to someone, you have a phone chat, get a coffee, kind of figure out if this person is on the level and able to communicate, and both people kind of know their lanes per se. And so, when I work with therapists all the time, and, we leave a quick little update afterwards and we kind of both know what we're doing. I might stay away from certain things because I know they're working on it, and then vice versa. And that seems to work really well. If someone can get a good team with a mental health professional who can focus on, the emotional stuff, and then someone who can, a dietitian specifically, who can focus on some of the biological as well as some of the, psychological stuff related to food, it's a really great team approach.
Absolutely. Thank you. So you mentioned a society that I'm guessing a lot of our listeners are going to want to look into, the conference that you said in London. Can you restate that? And then also, how can people get in touch with you and any other resources that you recommend to our listeners?
Yes, the ISNPR is the International Society of Nutritional Psychiatry Research. It's a relatively newly formed organization, so still in its infancy. And I was honored to present there with some of my esteemed colleagues from the NIH in October in London about substance use disorder and attend a bunch of the talks. And I got to meet some of the researchers that I've been citing over the years. So I don't know if it's every year or every other year at this point, but it's definitely something worth following. My website is nutritionin, that's IN, recovery.com. So at nutritionandrecovery.com, I give updates around all the publications that I put out, whether it be peer-reviewed journal articles, webinars. I sometimes make little videos. I have a newsletter that you can opt into. It pops in around 20 seconds. And I send out updates of all the stuff we're working on. And the major focus is nutrition for mental health, really being able to think about these topics in a new way. And hopefully you were able to stimulate some new thought today.
Thank you, David. You shared so many things that are absolutely fascinating. We could go down so many different rabbit holes in these different topics. Thank you for sharing some of this knowledge and for the passion that you're bringing to it, to be one of these people that's driving this information, this industry forward. It just sounds critical to where we're headed. So thank you. We appreciate having you today.
Thank you so much for the experience.
You've just finished listening to another exclusive continuing ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.